Welcome to Delightfully Dysfunctional, a podcast about navigating the emotions of the human condition and the challenges that come with it. I'm Keilani Persian Mason, a psychotherapist and life coach with James Timmons, an ever-curious human. This is not a replacement for mental health therapy. Please seek out mental health care if that's what you're needing. This is an opportunity for self-healers to dive deep and understand more about themselves. Welcome back to Delightfully Dysfunctional. I'm Keilani, and today I am joined by Dr. Amanda Downey. To me, Amanda is someone who is wearing a cape, and she tends to her patients and does such meaningful research that is creating the building blocks of deeper understanding into how psychedelic medicine can be used to heal not only the brain, but the body too. She is the assistant medical director of the University of California, San Francisco's Eating Disorder Program and the Translational Psychedelic Research Program, as well as being an assistant professor of pediatrics and psychiatry. She's basically a badass, and I'm also very honored to call her a friend. Welcome to the podcast, Amanda.
Oh, Keilani, thanks for having me. As you know, longtime listener, big time fan. So this is very surreal. I'm super excited to be with you.
Oh, thank you. I'm so excited. Those were a lot of big words. I hope I pronounced them correctly. Once you're saying them all at once, it's like a mouthful. All of your accolades.
Good.
Yeah.
Thank you.
Titles. Oh man, you know what's really exciting actually, we are friends and it's been such a fun journey that our friendship has taken, but these questions that I'm asking you today, I don't know the answers to all of them. And so I'm getting to know this other layer of you.
Mm-hmm. Yeah. I'm really excited to share with you.
Yeah. So let's just start with I'd love a deeper understanding of your upbringing and what influenced you to go into this direction and pursue a career in medicine.
Yeah, I have to tell you, I think that I'm my Midwestern parents' worst nightmare. I am from Ohio, from a very non-medical family, and move to California and start studying psychedelics. Like, of course, right?
It's
No,
good
but
for them. It's good for them to have a dose of that.
thank you. Hopefully they'll listen to this and
Yeah. We'll send it over.
Um, but yeah, no, it's a good question. I mean, I grew up always loving science, but I also loved, reading and music and more kind of creative endeavors and kind of putting those things together. I think I always had this kind of early sense of like how sacred it was to have authentic relationships. Like as early as middle school and high school, I just remember having this really like, yeah, just sense of how kind of sacred authentic connection was with other people. And so it's been kind of amazing to see that come full circle in medicine, in a way that I think we don't talk about. We think of it just as a scientific profession or a healing profession, but getting to be in deep relationship with my patients is profoundly meaningful to me and has really changed me. So, looking back, I think it does all kind of make sense. And then, foraying into research too, right? Like I just probably like you, right? Like I love to have little art projects and things I was working on as a kid. And now I get to play in that way in my career, right? I get to get like really obsessed with a research idea or project and get to carry that to fruition. So yeah, and in retrospect, it makes sense, but it hasn't felt like a linear path.
I really love how it was meaningful relationships that drew you to medicine rather than, I think many other people kind of answer from a place of like, I've always been interested in the science and how the body works. And yet it was like the connection that was really the core of it all. And even the way that you describe research took a different turn that I would have expected in such a fun way, because it was like, it's a creative pursuit as well. There's creativity that you feel within that research. And that's not something I've honestly thought about. To me, I think research, maybe I've like gotten a bad download. It's like, very regimented and controlled, but
Yeah.
I'm hearing a different element of that from you.
And it is that too, right? Like a ton of regulatory red tape and a lot of busy work. But yeah, at the end of the day, like I get to wake up and do science. I get to think about things that push the envelope, and that's a gift. That feels like a creative pursuit.
Yeah.
Yeah.
Yeah, yeah, like the creativity and just the questions that you're seeking answers to, and the process of it unfolding before your eyes.
Yes. And we have these care paradigms, right? Like so much of my medical training, whatever, 10 plus years is like, how do I fit into this paradigm? How do I learn the protocols and implement, right, in the structured way? And now I'm at a point that I get to say, okay, I've kind of mastered that piece. You never master it, but I know what I'm doing in that regard. And what can I change or tweak or create anew to
Mm.
make a better experience for patients and families, right? So it's a really kind of beautiful time for me in medicine, I would say.
Yeah, it's coming from such a heartfelt place. You shared, these kind of pieces of your upbringing and some things that really stood out to you that are at the core of your heart for this work. But were there any specific role models or experiences that come to mind that sparked an interest into the specific path of pediatrics where you began?
Yeah, it's a really good question and one that's actually kind of near and dear to my heart. I mean, I've always, kind of loved kids and again, kind of particularly adolescents, I think. And if you meet any doctors who work with adolescents, they definitely had a profound adolescence themselves, I would say. And I don't feel like mine is any exception. So yeah, my clinical work, and most of my research is still in the eating disorder space. And I really felt rooted in my experience as an adolescent walking with friends who struggled with eating disorders, and that informed my career trajectory and continues to inform my work. um, I think I had this sense. I had a lot of kind of like diverse friends in high school, and I ran into people from marginalized identities who I felt like were falling through the cracks of traditional eating
Mm.
disorder care, right? Like they were picked up later in the course of illness because they weren't the white, cis, straight, rich kind of female, like this kind of
Mhm.
stereotypical picture of who gets an eating disorder. So that was really motivating for me. And then also kind of realizing how folks kind of shifted between medical care in the eating disorder space and behavioral care. And feeling like, even well-meaning pediatricians were missing really critical pieces of eating disorder care, and then vice versa, right? Like even the best therapists, were missing important medical components. And so I wanted to be someone who could really hold expertise and space in the middle of those things to kind of provide holistic care. Uh,
Yeah, really bridging that gap, which I can
yeah,
and I totally understand too as a therapist. There's like so
yeah,
many things. Our brain and our body are interconnected. I'm always reminding my clients like we're one organism. It's not a separate function that's happening here.
yeah.
And it's exciting. It's exciting to get to be a part of breaking that paradigm, that
Yeah.
understanding that people have, and illuminating something that's really more holistic and true.
I think so. And to be clear, like I still need a big team and lots of support. I'm never
Yeah.
flying solo, or I try not to fly solo in caring for these patients. But it's been cool to be someone who exists kind of at that intersection where not many people exist.
Yeah.
Yeah.
And so this career path started as a physician doing pediatrics, and now you find yourself in this role that's like part physician, part scientist. How did that step or that how did that step come about? And also, did was it expected? Was it something you were planning and reaching for?
Not a chance in heck. Again, like 10 years of medical training, and holder of raging imposter syndrome, like many, I'm sure can relate to that. I always thought I'm just going to be a really good clinician, and that's fine. Like that's such a gift to the world if seeing patients, you can bring your full authentic self to those interactions every single day, right? But I would say for me, close to 8 years now in the eating disorder space in particular. Um, it became increasingly difficult for me to see myself operating in this same paradigm for another 30 years, right? Like as a physician, we're trained to be able to cure people, to have
Mm,
solutions to questions. And the reality of this field where it is right now is that less than half my patients really achieve
mm,
full remission, full recovery. And that's a really tough pill to swallow, right?
mhm,
So, in some ways, it became, almost like an ethical imperative. Like, if I'm going to stay in this field, if I'm going to love my patients and my families the way that they really deserve to be treated and cared for, like, it I have to do something else, right? And nothing is off the table for all these patients who my treatments are failing despite all of our best evidence and best efforts. And so falling into research was a little bit of happenstance in that way. Like, I can't wait on the world's smartest people to solve this problem. Like, why not me, right?
yeah.
But
I'm
it's
just
been
falling in love with
too.
you more, Amanda. I'm just falling in love with you more. But like, yeah, it was really coming from this place of kind of feeling a bit of hopelessness with the model that you had available to you. And again,
Yeah.
that heart for the people that you're serving to like, what else is there? And I totally relate in the same way that like mental health and working with my clients as a therapist and coach. It's like, I I want to be able to reach you, but there's this wall here. How can we navigate that? What tools do I have available or that are there?
That's right. I love this line. A dear mentor of mine asked me this at some point during my career, and I know she asked herself too. But she says, like, are you using all of your power and privilege to the best of your ability? Right. And that was a little bit of a turning point for me because I'm so lucky to be at a huge research institution that has an amazing psychedelic research program, right? And all of these amazing tools and kind of cultural assets in the Bay Area. And like the reality is, having an MD comes with a certain amount of power and privilege. And I wasn't using that to the best of my ability. And so again, kind of making this pivot into research felt like the only thing to do.
Yeah. When did it's just to get an idea of this timeline, when did that pivot happen? How long ago?
Yeah, great question. So, yeah, after 10 years of medical training, I took a faculty position in the eating disorders program at UCSF. And then maybe I would say 2 years into that clinical position, is when I said, this is going to be different now. And I had a lot of mentorship and support, to make that transition. But, was kind of working like evenings and weekends, writing grants and papers and trying to build a track record. And really over the past 2 years now have kind of a growing independent research career. So it's been in some ways relatively recent.
Yeah. Oh, how exciting to like really, I don't know, when you get to look back and kind of say thank you to the previous versions of you that helped pave that path and had that curiosity that just was insatiable.
Yeah. Oh, I like could get teary talking about it,
Oh, let's do it.
And I think to have, I think before really the past 5 years, I just was such a head down, I can do it alone
Yeah.
kind of person. Like I don't want to bother others in positions of power. So that this concept of like real, true female mentorship has never been more relevant to me. And I have seen the power of that in such a real way over the past 5 years that, man, I'm just so grateful without that kind of ushering in and love and care for me and not only my career, but like me as a person too.
Yeah.
I mean, there's no way that I could have made this pivot. So
Mm.
yeah, I'm
That's
really,
so
really,
powerful.
yeah.
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 Um, so I want to get into some of the research because we've been dancing around it, and I'm so curious about, yeah, the things that you are learning and discovering. So what's been coming up a lot is this initial passion too for working with eating people with eating disorders and having, I think we're about the same age, having like grown up in the same era. I don't know if there is a woman that grew up in that time frame who themselves didn't struggle with
Yeah.
some form of an eating disorder, disordered eating, or who didn't have a friend who did and got to see that firsthand, that struggle.
Yeah.
And that's incredibly unfortunate. And I think, again, speaks to um, the huge importance of the work that you're doing. So, what are some insights that you can share with us about your work and specifically how ketamine and psilocybin clinical trials are helping people with eating disorders?
Yeah, I'm really glad to talk about this. There's not a ton of published literature yet. We have one trial out of University of California, San Diego that's been published with very promising results and good safety data. Our trials are a little bit different, and maybe it's helpful to give a little bit of context there. So
Yeah.
our and I'm not the PI, I should say. PIs are Dr. Raymond Flesh and Dr. Woolley, fabulous, very creative, very caring individuals have crafted just this really beautiful clinical trial. It's specifically focused on young adults with anorexia nervosa. So we're dosing folks who are 18 to 25 years old. And just for context, like most of these people have still been suffering for over a decade, right? Eating disorders kind of strike in early, mid adolescence, like a lot of mental health conditions. And so it's not that, these folks have never had treatment before. Like these are people who really have been suffering chronically for a long time, even though they're so young. One thing we did really intentionally with this trial is consult with a youth and family advisory board. And so these are folks with lived experience of anorexia and family members who have experience caring for a young person with anorexia. And much of the trial design was informed by lived experience, by people in our community, even part of our eating disorders program. And so I think we're just really proud of that kind of angle, right? Not coming from top down and imposing what we think is right, but really trying to engage with the community. I hope that that's kind of the next frontier of psychedelic work. Um,
Yeah.
in that spirit, sorry, and then I'll be quiet about it. I just love this trial so much.
Oh, no, no, no. I'm here for it. I'm here for it. Tell us more. Yeah.
Yeah, something I think we're really excited about, again, because these are young adults who have been suffering for so long, we're really clear that the family system in which they exist is going to make a really big impact on their treatment. And so for the first time, we're including caregivers in therapy sessions around dosing because we really believe, like, as you know, right, family systems kind of organize or reorganize even subconsciously around mental illness. And so we want to prepare caregivers too for this possibility of like real and lasting change so that we're not just handing someone back into this family system that's going to reinforce kind of old patterns and old behaviors, right? We want to prepare the family for like this possibility of real positive, durable change. And so I think that is going to be a takeaway. I hope we're not even close to done yet, but so far that's been a really kind of profound addition to the clinical trial.
Yeah. I mean, this isn't my specialty, so I'm learning as I go, but that
Yeah.
feels very innovative to be incorporating family work into eating disorder treatment. Is that am I do you think is that accurate or
Yeah.
is
So
this
actually, yeah, it's so interesting. So actually, family-based treatment is the kind of gold standard evidence-based
ah,
care model for adolescents and young adults with eating disorders. And
okay.
the heart behind that model, and let me be clear, like this all comes from a place of love, right?
Hmm.
And the premise is that we're charging caregivers with refeeding the young person. We think that
Mm,
like their brain has kind of been hijacked by the eating disorder, right? And so
right.
the young person isn't capable of making good decisions about nutrition. So
Mm,
it's all about empowering the family system or the caregivers to re-nourish the young person
hmm.
that can feel the feedback we hear, especially from these people who have been suffering a long time, right? Is that there's kind of I don't even want to say the C word, but there's a little bit of a coercive element there, right? Or some of the like relationship is taken away because
Hmm.
we created this dynamic in treatment of the caregiver just refeeding the young person.
Right. Right.
Yeah, and like that saves lives. And at the end of treatment, there is an emphasis on kind of reorganizing the family system and more normal adolescent development. But I think what's different here is that the onus is really on the young adult
Hmm.
to decide about the change, right? To set intentions and then to bring the family members in. So there's less of this kind of hierarchical treatment dynamic.
Yeah. Yeah.
Yeah.
I can see how important that shift is. Just there's so much natural and healthy rebellion that happens in
Yes. Yeah.
adolescence.
Yeah.
So that previous model really it's kind of they're fighting one another, then the natural element of what's happening for that adolescent in their development, along with this like yeah, coercive was the word that you used. But yeah, exactly. That like feeling forced
Yeah.
I would see there being quite a rupture in that relationship.
That's right.
And it's interesting because the only context I really have for someone I knew who went to treatment, what they had told me, and this was like high school, way back when,
Yeah.
but this girl had been sent to like an eating disorder camp where they were assigned a horse, and if you didn't eat, your horse didn't eat. Like you're meant to like create a bond with the horse.
Wow. Uh,
I
oh,
don't know, right?
man.
Yeah.
I'm, yeah, I'm gonna plead the fifth on that, but part of me is like, okay, like you're at the end of your rope, nothing else has worked. Like who am I to judge that model? But yeah, I think there are a lot of problematic things that happen in the eating disorder space,
Yeah.
to
Well,
say the least.
and then again, like correct me if I'm wrong, because I'm learning so much already, but it's is it the most deadly or one of the most deadly mental health conditions
It's
is because of the damage it does to one's body.
That's right. Yeah. So there's about a 5 to 10% lifetime mortality rate. And the leading causes of death in anorexia nervosa in particular are actually number one is suicide, and
Mm.
number two is cardiac complications. So again, it's like this, kind of scary union of behavioral health and medical complexity. And you can see how so many of these young people fall through the cracks of either system.
Yeah. It also weighs heavy on me knowing and hearing those statistics because that means that there are quite a number of young people that you really cared for that that was they ended up as part of those
Yeah,
statistics.
yeah, the loss is not trivial.
Yeah.
And I think in particular when you're working with young people, young adults who have been suffering chronically for 15 years, right? And again, it's hard to understate what it's like to have a deep relationship with a patient like that and to know that you, outside of a clinical trial setting, that you have really nothing else to offer in
Hmm.
terms of an evidence-based roadmap is, yeah, it wears on you.
Yeah.
Yeah.
So, are there any findings that have come out then about the ketamine work and the psilocybin being an addition to these clinical trials?
Yeah, so not yet that I'm allowed to chat about.
Oh, man.
I know, I'm sorry. But
Hmm.
I'll just say anecdotally, first, our safety data is really good. We're dosing certainly a more medically compromised sample that's ever been dosed. So like going down to a BMI of 12, for example.
Oh, yeah.
These are really, really sick. And we have incredible medical expertise to kind of hold those participants through the trial. So I'm hopeful we'll get some really interesting data there. And then another thing I would just share, from early on in the trial's kind of life, is the amount of expressed emotion is
Mm.
really quite profound. I think, for our patients, or for many of my patients, I should say, there is a real kind of people-pleasing, perfectionist type of personality. That serves them really well, right? They're super successful at school. They're
Mhm.
deeply feeling patients. And once those defenses come down on psilocybin, man, there is some impressive emotion under there. And to get to see that come out in such an unfiltered and raw kind of way has been pretty interesting and pretty spectacular.
Oh, it's like giving me chills of excitement because I've seen that magic happen with my clients, and it's like, oh, you're getting reacquainted with that essential self, that part of you that has been there all along.
Yes, yes, and it for them to to just to get to access that even for a short time is so powerful.
Yeah. Oh, how very special. And this the altered states that these medicines are creating. Well, and I'll speak more to like ketamine. Like I see with my ketamine clients, the main benefit, like yes, the medicine can be somewhat of like a chemical mindfulness, and yes, there's this like window of neuroplasticity, but even more, it's this unspoken, deeper curiosity and commitment to growth and healing that before like there was a part that was kind of blocking some of that progress.
Yes, totally. And that's where, you and I talk about this often, but like I think the integration process is particularly critical. Again, my kind of world is in younger populations for adolescents and young adults who maybe don't have as much practice or frankly as much like executive function to be able to continue to work with that material over time, right? And so I tend to think that again, having caregivers involved and really kind of structured integration, maybe with a little bit more of a like, we always say integration is kind of non-directive, right? But I would say in our research in younger populations, we're finding that there actually needs to be just a slightly more directive approach to help folks make meaning of their experiences and to continue to work with the material.
Yeah, I can understand that. I wonder too, has art therapy and things like that been elements that have been compatible, I guess, with working with this population?
Yeah, it's interesting. We very intentionally incorporated some of that into
Mm.
trial design. And so we have kind of free form journaling, and we actually use that as part of the integration process. Is to
Yeah.
folks kind of doodle and write and draw and make poetry. And so as the trial is coming to a close, they're able to take that artwork back to their outside therapist who might
Hmm.
not have experience in the psychedelic space, right? But we find that kind of engaging in art that way actually helps with the integration process and then also kind of facilitates a warm handoff to their outpatient team. It's been nice.
Yeah. All right. So you gave us some taste, a taste of what's been going on. So just like blink twice if it's been promising and going
Yeah.
well. Yes. Yes. Everyone to YouTube. If you're listening, you got to find us on YouTube to see what happens.
I love it. I love it.
You've
Hmm.
also done research on the treatment of depression and bipolar 2 disorder. Can,
Yeah.
is that are the findings of that something that you can speak to?
I wish I'm writing them up as we
Yeah.
speak. So that trial
Okay.
is
We're on pins
completed.
and needles. Yeah.
In process, not yet published, hopefully out within a year or so. The data analysis process is very long, unfortunately, but we'll get it out
Yeah.
if we can. But definitely a really different population, right? I think a couple lessons there that stand out to me. Um, bipolar disorder alone, but I think especially bipolar 2 is a really kind of heterogeneous diagnostic construct, right? These participants are not, for example, young adults with anorexia nervosa. They have
Right.
come with extensive trauma histories, longstanding attachment issues, lots of other comorbidities, anxiety, depression, OCD, you name it, we've kind of seen it. And I do think that heterogeneity made the trial context more difficult.
Mm.
Um, and I think, yeah, our lab, the Translational Psychedelic Research Program, we
Hmm.
call it TRIPPER for short, which we think
Oh,
funny. Um,
that is funny. I like that.
Thank you, thank you. Not my idea, I should say. We're really committed to being very transparent about adverse effects.
Mm.
there have been some other bipolar clinical trials published, and they just feel so kind of clean and neat, and safety data is great. And we had good safety data too, but we're going to be very transparent about some of the challenges in terms of dosing this population. And I do think this is my anecdotal experience, but again, things like trauma and attachment issues, there's no question that those participants experienced more challenges
Mhm.
with psychedelic therapy. And
Right.
I think the more, again, we're not just doing things to make the clinical trials look good and the results promising, because they are, but like also people really need to know what is the risk profile here, right, for different clinical populations. And so certainly we saw some of that. I do think kind of one caveat to that though is something we struggle with. Clinical trials are so protocolized. So if
Mhm.
there's 3 sessions of integration and someone is struggling, we can't just say, oh, we're going to do 3 more. That's what they need. Like, that's just not the way that research
Mhm.
works. And so my hope is that with regulatory approvals, and then clinicians have some more kind of leeway in terms of personalizing these treatments, that we can mitigate some of those adverse effects, right? And that's something that you don't see translated from the scientific literature. Like how will that work in a real world clinical setting? And so I spend a lot of time thinking about that too.
Right. Yeah. Oh, it's so interesting to hear from someone who's doing the work and in the different protocols, more of the heart of what's behind this. And
Yeah.
I'm also hearing that there are there are some studies that feel a bit more on the clinical end, a bit more just like we're wanting to get those findings or feel like we're not painting the full picture. And here you're really wanting, like, I want us to really understand and be able to share with the public of a full picture of what's happening here.
Yeah, and I think that that's a little bit just like the culture of our lab, right? I don't
Right.
say people aren't being fully transparent.
No.
Um, but there is discretion in terms of what you report and how you report it. And are you calling this adverse effect related to the intervention? Are you saying, this person would have had that anyways, right? So, as much as we try to keep things really clear and rigid, like there's
Mhm.
actually a lot of gray area in research. And
Yeah.
so I hope certainly our lab is swinging towards more transparency, more reporting, getting the data out there for everyone to understand. And I was going to say between you and I, but that doesn't make sense in this context. So between you, me, and everyone listening, I guess, I mean, that is part of the reason I think the FDA wasn't comfortable
Mm,
approving MDMA for
yeah.
PTSD, right? Like there was a lot of controversy about the way that AEs or adverse events were reported transparently or not.
Mm.
And so I think the field, it behooves us to have more transparency.
Yeah, yeah. In terms of other research that has felt really exciting with psychedelics treating mental health,
Mm.
what are findings that have been released and have been out there that you've consumed that
Yeah.
feel inspiring to you, hopeful?
Yeah. Oh, thanks. I love this question. So I'm a little bit of a mechanism nerd. And so what I mean by that is I'm really interested in, okay, so we know, for example, that, psilocybin therapy for depression yields this good result, right? For many people. But what is happening? Like, what is the change in the brain or the body that gets us from point A to point B? And some people might say, like, well, who cares, lady? Like, if it works, it works. And I feel that deeply too, right? But the reality is, to get these things approved, we have to demonstrate what's called mechanism of action, what's going on in the brain or the body. And so I think the findings there for me that are really exciting are kind of threefold. And this might be old news to you and your audience, so I apologize if that's the case.
No,
But
we're loving it.
yeah, okay. So, the first idea is that psychedelics are anti-inflammatory agents,
Mm,
right? So, there's been long-standing kind of scientific inquiry into this idea that is mental health actually kind of an inflammatory condition,
right,
right? Was there
right.
virus or some other kind of dyssynchrony in the body that's caused an inflammatory cascade. And can psychedelics quell inflammation?
Mm.
Pretty good
Mhm.
evidence now to say that yes, there is psilocybin in particular, classical psychedelics that work at the 5-HT2A, the serotonin 2A receptor, are pretty potently anti-inflammatory.
Wow.
Cool. I think that's good news for both mental health and when we're thinking about physical health too.
Yeah. Yeah, because
Like,
they're so intertwined once again. And having like continue to do some more research from this holistic place into even diets that improve mental health. It's everything anti-inflammatory. So
right,
it's right,
right.
it's follow we're sniffing down the same path.
That's exactly right, just kind of from different angles. So I know our lab right now, in collaboration with Stanford, we're running a trial using psilocybin therapy for chronic pain,
Mhm.
right? And so it's not only, okay, can the psychedelic experience change our relationship with pain, but also like what's going on from an inflammatory standpoint, right? That also could change pain. For
Right.
that's really exciting to me. That was number one. We'll see if I can stay with all three. Number two, neuroplasticity, which I know
Mm.
you're not a stranger to, right?
My
Again,
favorite word. Yeah.
good. It's so good. And it's so, the researchers will like kill me because it's kind of like saying cognitive flexibility. Like it's this
Right.
really broad construct, right? With all these like kind of more specific delineations underneath. But we're just going to say neuroplasticity for
Hmm.
this. Synaptogenesis, growing of the neurons, creating new neural pathways. We know that psilocybin, again, I'm sorry, I'm like a psilocybin stan, but the classical
I
psychedelics.
love, look, I'm wearing my mushy shirt. I'm ready
Uh,
for this.
Thank you.
Yeah.
We're
Yeah.
on the same page today. Oh man. So there's something again about that action at the 2A receptor that causes this really rapid period of um neurogenesis, which is so exciting. We can't, maybe SSRIs do that over the course of years, but nothing like the time course we're seeing with psychedelics.
What an exciting time to be doing this work.
Oh, I feel so lucky. I feel so lucky. But with that process, right, comes unbelievably great responsibility to
Mm.
make sure that those pathways are forming in a positive and adaptive way.
Mm.
So that's number two. I would say the third thing I'm really excited about is ongoing like neuroimaging studies. So looking at things like fMRI, right? What are the changes in neural networks that are happening under the influence of psychedelics? I just got a grant to also add EEG, so measuring like brain waves.
Mm.
As another kind of marker of neurocircuitry in response to psychedelics. We know, again, cut me off if this is too much, but
I mean, like, I'm eating it up. I hope there's other nerds out there who are doing the same.
We're
I think
into
so.
it.
Yeah, we
Right.
travel together.
I love it. You've heard of the default mode network, right?
Right, of course.
Kind of like hub of self-referential processing for
Right,
patients. Folks with an overactive DMN get stuck in this loop of, I'm so fat, no one could ever love me, right? We're
right.
quiet that region with psilocybin, which allows for this more kind of like appropriate contextual balance between self-referential processes and executive functioning. So like, does the salience of food and nutrition, might it change if they can get out of that stuck default mode network? So anyways, those are the things I'm thinking about.
Yeah. So for the listener, you gave a bit of description, but that default mode is this like very stuck and rigid way of thinking where it's difficult to see any other perspective outside of this box.
Yeah,
Or acting in a way outside of this way that has been just such a well-worn path that
that's
it's
right.
difficult to be able to picture or even take the first step down a new trail.
That's exactly right. And so, Robin Carhart Harris, very prominent in the psychedelic space, talks about psychedelics shaking the snow globe, right? Like you've got these deeply entrenched paths that you just can't get out of. But then it's like you take psilocybin and you're shaking the snow globe and you're allowing the snow to settle in new and different and adaptive patterns of being. I think that's the best non-neuroimaging way to describe.
Yeah, right. Yeah, we gotta bring it down to the layman. But that I like
No,
that
no, no, no.
imagery. I love that imagery.
Yeah,
Um,
me too.
There was someone that I knew who took quite a large dose of mushrooms for the purposes of wanting a really therapeutic experience and to
Yeah.
really do the
Oh.
work.
Mhm.
And like they really didn't feel they didn't feel the effects. And I wonder if there's been cases like that in your study where for most people, this would definitely be a dose that would be noticed.
Yeah.
Maybe it's a psychological piece, a subconscious piece that's blocking it, or maybe it's something more complex, like just the biology of a person.
Interesting. So they took a large dose but didn't have like a true psychedelic experience?
Right. Yeah, of mushrooms, of
Oh,
psilocybin mushrooms. I'll
yeah. So
send them down to you. You can study
oh,
them.
bring him to the lab. No, I think a couple thoughts there. So we know that folks who are taking a serotonergic medication, like an
Right.
SSRI, for example, right, can cause a blunting kind
Mhm.
of response to something like psilocybin. So,
Sure.
anecdotally and certainly in the lab, folks who have been on SSRIs or SNRIs, other meds for years and years tend to have a less lessened
Right.
intensity of
Yeah. So
experience.
don't
So
play as well with psychedelics, the
that's right.
SSRIs.
And
Okay. Right.
actually, like in terms of safety, and this is, I should like caveat asterisk, this is not official medical advice. Don't do what I'm saying. But in terms of safety, it's probably safe. We
Mhm.
used to worry about something called serotonin syndrome, where your brain gets flooded with too much serotonin. That can be very dangerous. In fact, it probably is safe. It just attenuates or lessens the intensity of the trip.
Okay, wonderful. That's good information to just have
That's right.
available in my mind.
Thank you so
Yeah.
much.
Thank you.
But then more generally, I think certainly there are, biological and genetic differences in things like
Mhm.
in different serotonin receptors, for example, that probably also do change one's experience of a psychedelic trip. And my hope is, 20 years from now, for example, that we will be able to do maybe a serum, like a blood test, or a quick neuroimaging, quick
Yeah.
stop in the MRI or an EEG to find out those kinds of things. So we can really personalize and tailor these experiences based on your own kind of, phenotypic profile.
Yeah, I love that. It's really honoring the complexity of each human and the differences that we have, where I think thus far in the field of like psychiatry for mental health, it's like here's these very limited options available and that's all you have and it is going to work for you because that's all we've got.
That's right. It's just science. Yeah. Yeah. No, that's my hope. Like, in some ways medicine can be so precise and in other ways, man, there are days I'm practicing and I'm like, this is so brute. I mean, this is not nearly as precise or intricate or
Right.
as honoring of the individual, complex individual sitting in front of me as I hope we'll see in 20,
Right.
50 years. Who
Well,
knows?
I think that that's the real complication with mental health, where if someone has diabetes, it's very easy to determine how much insulin exactly that you're needing, or if there are other disorders that someone has. There's so much that blood work can tell us, and with mental health, it's complex. We're looking at symptoms, we're looking at emotions. Those emotions can change and shift. There's trauma. There's biological aspects. And so, yeah, you took a doozy of a field to dive into, but I mean, the field is so lucky to have you.
Oh, well, I feel the same about you. And, as you know, right, it's so complex, right? And so much gray and so few right answers. And like being in this field really makes you reckon with your own stuff too,
Mhm.
right? And sitting with other humans and
Yeah.
thinking about these research questions, that it's challenging, but it's awfully special, you know?
Yeah, yeah. I think to do it with to the highest ethical standard, it does.
Yeah.
It forces you to look at yourself, and that's the beauty. And at times when that feels painful, maybe the curse.
Uh-huh, uh-huh. Say no more.
Yeah, yeah. Like, oh, dang, I have to look at my childhood trauma. I didn't know
Gosh,
that was a
yeah.
part of this. Right. And just sitting with people for their deep pain. I mean, powerful moments of emotion that takes a different kind of circuitry for someone to really hold that space. And it's so special.
It is so special. And to bring it back to psychedelics, like how special to be in a field where I feel like, maybe for the first time, like we're really, really trying to honor all of those things, right? All the complexity
Yeah.
person walks in the door with, and thinking about things like set and setting and the family system and caring for them medically, right? Like all of these things are present, and we're not doing it perfectly yet. We probably never will, but like to get to reckon with all of that is extraordinary.
Yeah. So exciting. And so you've shared a little bit too about parts of this future, the future of this work and the future of caring for people and what that could look like. Is there more that you envision when you think about the future of psychedelic research in medicine and
Man,
psychedelic and treatment too? Just, not just research, but like treatment.
yeah, it's such a good God. This could be another hour, so you have to cut me off.
Yeah, no, fuel up. Let's take a
Uh,
sip of caffeine. All right.
no, oh God, there's so much, Keilani. A controversial area that I will highlight but not give an opinion on
Hmm.
strategically is this idea. There is a lot of momentum and interest in developing a non-psychedelic psychedelic compound.
Oh yeah, I got opinions on that though.
Yeah. Okay, well, if you want to share, I'm totally down for that. But I do think, for good reason, there's a lot of profit motive to find something like that, um, to take away the trip, right? That could
Right.
be cause some to have challenging experiences, etc. A lot of profit motive. Yeah, do you want to say anything about that?
I think that it's very short-sighted, and I feel as though that trip that is what creates that altered state, and you need that bit of magic and that bit of wonder and awe in the experience. It gives an experience, like I even like talking about it. It's almost like revisiting the feeling in my body. Like your whole body gets to have this different experience of being and seeing the world, where if you're taking that away, that's not even the same thing. It's not the same medicine. It's not a holistic treatment really of what's going on in the same way. So I have concerns and I have real doubt.
I think you're in excellent company in that opinion. 1,000%. I guess for me, I won't even call it a counter argument, but another kind of side of that coin is
Mhm.
how resource intensive psychedelic therapy is in its current form.
Right.
In terms of in clinical trials in particular, most trials require two therapists for every single session.
Right.
We're talking in some cases of up to 80 therapist hours for one course of psychedelic therapy. The cost is tremendous.
Yeah.
And so at the end of the day, we also need to be thinking about how this is scalable and accessible, particularly for minoritized people who
Hmm.
disproportionately suffer the burden of mental illness but can't access treatment. So I will say I share many of your sentiments in that regard. And
Yeah.
if there's a way to make this scalable and accessible in a way that still offers relief and help, um, I am open to thinking about alternatives in that way.
Right. Yeah. What creative solutions can we find to make it accessible? You're so right.
That's right.
Um, my hope is that we can train, or there can be a tier of people who are trained to do that and be really ethical still. And it's not taking the actual therapist's time, but someone who can still hold that space and help someone feel safe and reduce harm, well, they're getting that preparation and integration that's necessary with their therapist. And it's like this team effort. That's like a piece of the vision that I hope for, and group work. I mean, we got to, how lucky am I? I got to experience like group work with you in our training, and that power of connection, human connection, meaningful connection that we're all craving so much.
Yes.
It's like tilling that soil for the medicine to do its work and create that safety. So it's so conducive.
Yes. Oh, I couldn't agree more. Actually, before I was part of our lab, one of the first psychedelic studies done at UCSF was actually a group study, um, looking at AIDS survivors and kind of their grief and mental health symptoms.
Oh,
And so that is very much on the radar. This is like another one of those crappy, like you're limited by research protocols issues, because when you try to study a group, um, it becomes, gosh, how do I say this in a way that makes sense? In terms of statistical analysis, a group of
uh-huh.
people kind of becomes one person.
Mm-hmm.
Well, the results, the more people you
Right.
have in a trial, the more kind of powerful the results
Sure.
are. Or
The
more,
bigger the sample size that you're getting to study, then you have a more widespread data points to
you
represent the
got it.
population. Am I
Like
following kind of?
you're hired.
Okay,
You're
I'm
hired.
working
One
really hard.
number. Yeah.
Statistics was
Done.
not my strong suit. So,
No, but that's it. But it's really hard to incentivize clinical trials of groups
right.
because they're not considered as robust in terms of showing an effect or a change from
Hmm.
before to after the psychedelic work. So, anyways, that's a tangent, but I agree with you. I would love to see more group work. And then I kind of already alluded to this, but this idea of how can we kind of screen and personalize things so that we know, like for this person, psychedelic therapy is going to be an excellent, game-changing, safe intervention. And
Mm-hmm.
for this person, because of their genetic makeup and or their phenotype, meaning, what kind of clinical symptoms they have, this is a much kind of riskier venture. Uh,
Right.
so yeah, thinking about how we can screen and tailor to really
Yeah.
know for whom is this a better intervention.
Yeah, and I think that would reduce a lot of anxiety that people have going into it, because I think it's very natural to have anxiety, even if it's like it's you're good to go. This is going to be a good medicine, but there's
Yeah,
this unknown that we're still trying to understand.
really agree. And then I'm curious to get your thoughts on this. Excuse me. Um, I'm curious about like how you feel about like licensure requirements and kind of mandatory trainings for clinicians who want to work in this space once it's gained regulatory approval. Like that feels
Hmm.
ethically hairy to me. Like, do you think there needs to be kind of a national or international set of standards that people are following?
I mean, ideally that would be the case, but even now, state by state, the requirements to become a counselor are so varied. So that it becomes difficult to think about it being a reality anytime soon. But
Yeah.
if I had my magic wand and in a perfect world,
Mm.
then I do think that that would be a really beautiful like way to give continuity and a standard. I
Yeah.
sometimes have some concerns about like the gatekeeping and the ability of access for even clinicians who are wanting to have more training,
Yeah.
with the price point or even
Yeah.
the necessity of some of the courses that are
Yes.
included.
Yeah.
And that maybe there could be a tiered approach,
Yeah.
perhaps, that makes it more accessible and easier for people to get a foot in the door and practice this work very ethically. But those are some of my thoughts around it. I hope that there continues to be states that consider other models, because right now there's really only a couple, and that's not a lot to go off of. I mean, I understand then that they're going to kind of be modeling off of one another.
Right. And without federal approval, it's all kind of moot anyways.
Right.
Yeah, I agree with you that that's a hairy conversation, but I think some degree of consensus around best practices will
Hmm.
serve the field well.
Yeah, yeah.
Yeah.
It's such exciting work to be a part of. I am just really, it's such powerful moments that I get to witness and I'm so honored by with my clients. And I think it's again, it's just so incredibly exciting. And I think that you're doing such amazing work that is so needed for our society and our world. It's really like your whole career is like a love letter back to humanity.
Oh, thank you for saying that. Yeah, I'm really touched by that. Thank you.
I was like, oh, it's making me tear. Oh, oh my goodness. Amanda, thank you for your time, for your expertise, and for really shining a light into an area of the research end of things that I haven't gotten to have these kinds of conversations. So it's so fun to learn more.
Thank you for having me. This was such a gift. Anything to spend a couple extra minutes with you. It's been really nice.
Well, I'm gonna have to rope you back when these studies come out so that we're not communicating through Morse code blinks. But yeah. Yeah.
I would
So
love
excited
that.
to have you. We'll be in touch. And thank you so much for joining us and being a delightful human yourself.
Thanks, Keilani. Mm.
Bye, Amanda. And delightful humans, we will see you in the next one. Thank you for joining us on Delightfully Dysfunctional. Bye bye.